Okay, sir.
Yeah, yeah.
So the topic is really interesting. It is granulomatous myocardial diseases and its clinical spectrum and management. So as a whole, these granulomatous disorders, they comprise of a large family of diseases, and they have a common histological denominator of granuloma formation. Now, this granuloma, they can be confluent or discrete, and the degree of necrosis and the content of the cells or the presence of different bodies like the Schwann bodies, the residual bodies, the Ashoff nodules. So there are certain features which are differentiating in the components, but all these diseases, they have the common factor of granuloma formation. And as we all know that this granuloma is a complex interplay between the immune system with the antigen or the irritants like the chemicals or a drug or a infective agent, leading to a T cell response, a B cell response, immune fixation. Ultimately, there is a healing process going on, which involves fibrosis, calcification also to some extent, and ultimately leads to a granuloma formation. If we look at the history of these granulomatous myocardial diseases, it dates back to almost a century ago when it was first diagnosed, a cardiac condition was first diagnosed called giant cell myocarditis, or it was better known as Fiedler's disease. And such patients, they had a acutely developing LVF and ultimately lead to a very fatal condition. And most of these entities were diagnosed in autopsy series. And because autopsy was not that much common, so there was basically an underestimation of the actual figure. The incidence was very low as shown in those times. But gradually we came to know that this giant cell myocarditis as well as cardiac sarcoidosis, they belong to a same spectrum of granulomatous diseases, and ultimately they are causing myocarditis or arrhythmias and causing this from granuloma formation. And with time again, we came to know that no, this GCM and sarcoidosis are not exactly the same, though they belong to a similar spectrum, but they have significant differences in presentation, histology, and prognosis. So if we think of this GCM, giant cell myocarditis, or cardiac sarcoidosis as a spectrum, there are certain similarities. The most important similarity is in the number of giant cell, presence of giant cell in the granulomas in both conditions, but obviously there are certain differences. GCM was more associated with autoimmune disorders or tumors of the immune system like the thymoma or lymphoma. And some association was also noted between parvovirus or Coxsackie B virus infection, although electron microscopy did not show the viral particles. And also in the cell component, like the GCM, they had a more of myocyte necrosis, more of eosinophils and lymphocytic infiltration. Whereas cardiac sarcoidosis, on the other hand, had less prominent myocyte necrosis. And if we look at the prognosis of the clinical course of the disease, cardiac sarcoidosis was having a much benign or a benign course or a better prognosis, so to say, and less fatality, and was having more of bradyarrhythmias, whereas tachyarrhythmia and LVF was more with GCM. So we came to know that this sarcoidosis is basically a different entity. And at this present discussion of granulomatous myocardial diseases, I think, or we all should know that sarcoidosis is probably the most important entity which we should study in details. It is a multisystemic inflammatory disorder, we all know, and the hallmark is a non-caseating granuloma formation in different organs, which either resolves on itself or with treatment when the inflammation subsides, or it proceeds to fibrosis and residual permanent scars. So there are non-caseating granulomas. They include certain bodies, which is remembered by the mnemonic SARC, Schwann bodies, asteroid bodies, residual bodies, and crystal hyaline inclusions. And there is rarely necrosis, although they can lead to some calcification in the healing stage. So the clinical features, they again vary from asymptomatic to fully organ failure. Mostly involved organ systems are respiratory system. There are also certain cutaneous or occupations, and obviously there are symptoms of systemic inflammation like low-grade fever and fatigue. But if we look at what is the involvement of the cardiac musculature, this is hardly 2 to 3% in presentation or follow-up, and in the present studies also it is less than 5% in all if all the cases of sarcoidosis are studied. This is a scoring system. I will not go into the details of the scoring system in chest X-ray, but yes, there can be nodules, there can be miliary opacities, there can be linear or reticular opacities, and ultimately there can be cavitations also. And particularly coming to the heart now, it leads mostly to heart failure by diffuse granulomatous involvement of the myocardium. It also leads to conduction system and valvular diseases. Among the conduction system, complete heart block is the most common abnormality. As I said, bradyarrhythmia is more common than tachyarrhythmia. But also this tachyarrhythmia can occur, particularly VT, from scars as well as from inflammatory milieu. And there may be requirement of ICDs or other ablation therapies. I will come into the details of those. Now, this cardiac involvement is the second most leading cause after the leading cause of death after pulmonary involvement. It is one of the most important cause of morbidity and mortality from progressive heart failure or arrhythmias. We have to remember that the RVOT is a very common site of idiopathic arrhythmias or ventricular arrhythmias in such patients. And also there is outflow tract VT. Certain other echocardiographic findings, suppose if we find a wall motion abnormality or we find a distinct enlargement of the left ventricle, may suggest certain other structural heart disease rather than only sarcoidosis itself. These are the diagnostic tools which we have to use for diagnosis. And obviously, we need certain diagnostic criteria because the diagnosis is challenging. The HRS expert consensus in 2014, they said that there is a histological line of diagnosis and a clinical line of diagnosis or pathway of diagnosis. And there had been some updates recently also. So if you look at the histological pathway of diagnosis, we need a positive endomyocardial biopsy. But because the disease is patchy in nature, that has a very low sensitivity, because if we collect the specimen from a normal area, we may not find the granulomas. And if you go by the clinical pathways, we require histological evidence of sarcoidosis in extracardiac tissue and coupled with clinical evidence of cardiac involvement, which is consistent with sarcoidosis. And MRI or PET study can help us. So as I said, it has to be if it is a endomyocardial biopsy showing granulomas, then it is a definite diagnosis. If it is extracardiac sarcoidosis histological evidence with clinical features of cardiac involvement, then it is a probable diagnosis. And what are the clinical involvements? It is mostly a heart block or a cardiomyopathy which is responsive to immunosuppressants, or it is an LV ejection fraction less than 40% unexplained from other causes. There are certain other clinical pathways for diagnosis also, like if we find a sustained VT without any other causes, or if we find an abnormal FDG or a gadolinium enhancement in MRI or a gallium scan, which is the pattern is resembling cardiac sarcoidosis, then with the help of PET or MRI also we can say that or we can suggest the diagnosis of sarcoidosis. This is just to show you the arrows are showing certain scar tissues, and the PET FDG PET scan showing active inflammation around the scar tissues in a patient of sarcoidosis. So we have come to know that there is a very small involvement of less than 5%, but it is only overt cardiac involvement is 5%, whereas unrecognized or histological involvement can be up to the extent of 20 to 30%. So that is not a very low figure, and probably we are not estimating the actual number of cardiac sarcoidosis, and we are treating them with some other therapies like ICDs or ablations, and not addressing the actual inflammation of sarcoidosis. So if we look at the echocardiography, it is mostly with a normal echocardiography, and even ECG is only abnormal in 1/3 of the sarcoidosis patients. And if we look at the ECG abnormalities, there is a particular prevalence of idiopathic outflow tract VT-like picture or PVCs, particularly in the early stage and in relatively young patients. And so we keep on treating those patients as idiopathic outflow tract VTs, and we are not searching for the underlying sarcoidosis in them. And we are treating them with antiarrhythmics, we are treating them with ablation, and the undergoing smoldering inflammation is not addressed. And what happens is the outcome is recurrence of VT or a progressive systolic dysfunction reaching a stage when it is not reversible. So sometimes ablating these ventricular arrhythmias is actually delaying the correct diagnosis or the initiation of treatment, and actually maybe increasing the morbidity and mortality. So as I said, that outflow tract VT is an important conduction abnormality present in the baseline ECG of such patients, and that should be considered as a surrogate marker of abnormal substrate or scar. But this is an interesting feature. This is a paper by Dr. Narasimhan, and this has given us a particular algorithm, a very distinct algorithm of how to suspect cardiac sarcoidosis. And what he says is fragmented QRS is a very consistent ECG finding in such cases. And it was significantly lower in controls having idiopathic VT. So fragmented QRS is what we should look for, and in absence of prior myocardial infarction, this is an conduction abnormality that should prompt us to exclude this condition. Low voltage QRS is also an important marker of cardiac sarcoidosis, and if we find VT, obviously we have to think of immunosuppression, antiarrhythmic drugs, ICDs, and radiofrequency ablation. VT management, ICD is almost always advised as a secondary prevention of death. We almost give all patients with antiarrhythmic drugs and particularly beta blockers, but we have to look for active inflammation. And if the patient is having active inflammation, we must remember that this patient is going to respond well to immunosuppression. So immunosuppression is not suitable in those patients where there is no active inflammation, or where the underlying substrate for VT is a scar. So in those situations, obviously ablation is a better treatment modality, or as I said, secondary prophylaxis, giving an ICD or something, an antiarrhythmic drugs is the alternatives we have to think for. If we can detect this early, if we can early detect this cardiac sarcoidosis in VT patients, what we can prevent is a progressive LV dysfunction. We can also prevent unnecessary upgradation to cardiac transplantation or other devices. And this is an important message, that this PICM, that is pacing-induced cardiomyopathy, this is an entity. Suppose if we are giving a dual chamber or a single chamber pacing to patients, 10% of such patients will develop LV dysfunction over due course of time. But some of these patients are also having underlying cardiac sarcoidosis, which we may not address, and we maybe think that pacing, RV pacing, is deteriorating his or her LV function. So that is again we should look for rather than stamp it as PICM. There is obviously role of immunosuppression, particularly corticosteroids, in patients who have active inflammation, and we have also found that there is resolution of the arrhythmias, particularly AV block, and resolution of the LV dysfunction with steroid therapy. And if there is, as I said, that so we need a different treatment approach in different stages, depending on whether the patient is suffering from active inflammation or he is having a scar tissue or something. Now, this another entity, that is cardiac tuberculosis. This cardiac sarcoidosis and cardiac tuberculosis, often they are confusing, and they often can have a common presentation with such granulomatous myocarditis and conduction abnormalities. So that is another entity which needs to be studied a little bit to separate it from cardiac sarcoidosis. As we know, TB can affect any organ in the body, but the involvement of the heart is very less. It is hardly 0.1% to 2% of TB patients, and it mainly involves the pericardia. The exact mechanism of TB myocarditis is not very clear, but there can be hematogenous seeding, there can be direct infection from the surrounding tissue like the pericardium, or there can be retrograde lymphatic drainage from tuberculous lymph nodes, mediastinal lymph nodes. This involves mainly the young, and we always have, invariably, we have coexisting evidence of tuberculosis elsewhere in the body. Males is...
Dr. Mani.
Yes, sir, another 1 to 2 minutes. And LV is mostly involved, followed by RV, RA, and LA. There can be pericarditis, rhythm disturbances, both ventricular and supraventricular tachycardias. And as I said, myocardial involvement can be there, can lead to SCD also, sudden cardiac death. there can be nodular or miliary pattern, or there can be an unusual diffuse infiltrative type of tuberculosis affecting the entire myocardium. These are the tests we all know: CT scan, AP scan, TB PCR, quantiferon, bronchoscopy, and MRI, and obviously we can do a endocardial biopsy. And this is the last entity I should mention, that there is an entity called idiopathic granulomatous myocarditis. Also, although it is very rare, it is usually present in 3rd to 4th decade of life, and autopsy findings show granuloma in heart as well as in liver, spleen, and other organs. But it is not showing any acid-fast bacilli or a fungal or any other particular bodies like the Schumann bodies or asteroid bodies, which can indicate sarcoidosis or other distinct entity. So few other differentials, which usually is not very confusing, but still in certain rare cases, diphtheria or rheumatic fever or beriberi, sulfonamide reactions in myocardium or glycogen storage disease may be confused or may present like these granulomatous myocardial diseases, which we also need to look for. So to summarize, particularly with this cardiac sarcoidosis part, the diagnosis is obviously very challenging, and we need more sensitive and specific criteria for it. CMR and PET should be what we should be trying more and doing more in such suspicious patients. But also there are certain ECG findings and algorithms which may indicate early detection of, which may help us in early detection. And future guidelines should highlight the high incidence of ventricular arrhythmias in such patients, particularly involving the RVOT and immunosuppressants, because it may be helpful to treat myocarditis or arrhythmias, in particularly in patients with active inflammation. So this disease should be diagnosed early. So thank you. That's it.
Thank you very much. So to start the questions, since we have a very short time, I'd first give the opportunity to Dr. Shumanta Chatterjee. So please ask a few questions and make sure these are not got up on.
Thank you, sir. It's very prestigious thing to share a same platform with Shodo sir, and thank you, Dr. Goa sir and Dr. Shodo sir, to giving me the opportunity. So, excellent academic feast is going on. So, coming to the topic, that this peripartum cardiomyopathy and tachycardiomyopathy, these two are temporary or transient dilated cardiomyopathy, and only HEP-REP is being considered here, not the HEP-PEF one, because tachycardiomyopathy and peripartum cardiomyopathy both can cause HEP-PEF also, but probably to retain its reversible, quote unquote, reversibility. So they're retaining that less than 45 or HEP-REF part. So here the main problem is treating the heart failure. So the usual tools of heart failure, there is beta blocker, MRA, ARNI, and SA inhibitors. We cannot use those things, or the period of using these things are smeared, because it is a temporary one. After 3 months or 6 months, whenever the patient recovers from 30% to 50%, how long we should continue these tools of heart failure, it is a very difficult one. So that's why I am asking Dr. Somnath or Dr. Karak. So how to unload the patient, or how to wean off those patients from MRA, beta blockers, or AC inhibitors in peripartum cardiomyopathy or tachycardiomyopathy, because they are supposed to be temporary or transient ones.
See, in case of peripartum cardiomyopathy, that is a very pertinent question. In peripartum cardiomyopathy, actually it is said that you have to have around 50% ejection fraction or more, and you have to evaluate 6 monthly, and you have to wean from single drugs one by one. You have to take time. You have to monitor. You have to monitor for around 6 months, 3 to 6 months. Then you have to wean off serially. It is very difficult. It is very difficult, and you never know that which patient is going to the complications, having 25% among the 25% who have complications, and among the 25% who have persistent LV dysfunction. So it is very difficult.
Actually, in dilated cardiomyopathy, where there is an HEP-REF, so if we give this beta blocker, AC inhibitors, or ARNI or MRA, and we see in a follow-up that after say 6 months, after say 1 year, after say 5 years, patients improved from 30% to 50%, though, however, it is a rare one, but we have to continue it for at least 2 years. there's a some guidelines are there that you should continue it for 2 years and then gradually wean off the thing. But here in peripartum, there is 6 months. They have given a short of 6 months. Then it is very difficult for us.
But there is no specific guideline of that 6 months. Only some up-to-date recommendations. I have found some up-to-date recommendations and some clinical studies where they advised, but there is no guideline recommendation to wean off the therapies.
Okay, question to Dr. Basav. So, as you know that these patients with hypertrophic cardiomyopathy have got different types of symptoms. So, the greatest problem here is what we are going to do to a patient of hypertrophic cardiomyopathy who is presenting with severe dyspnea.
So first we will have to identify the cause of dyspnea. Dyspnea can be due to diastolic dysfunction. It can be due to the LVOT gradient, which on exertion produces the symptom of dyspnea. It can be due to reduced ejection fraction in burnout cases. So accordingly, we will have to act in for diastolic dysfunction. Also, it becomes quite challenging because we cannot give higher doses of diuretics than the patient may develop subclinical obstruction may become evident. So very carefully we will have to optimize the diuretic dose, and we can give beta blockers. One patient has become euvolemic for not only rate controlling and but also due to the its disease modifying and ischemia reducing capabilities. For LVOT obstruction, we should, if it is not evident by normal echo or Valsalva, we should see by other methods of provocation, as I have discussed, even stress, or we can go up to the extent of cath also to elicit the LVOT gradient. And if LVOT gradient is available and not controlled with beta blocker plus minus CCB or with
I'm just interrupting you. My question was very specific because these are the practical things you see in your life. Because I treated a patient of hypertrophic cardiomyopathy who had a mid-ventricular obstruction here in North Bengal. So the patient has severe dyspnea, and to start with, I gave beta blocker and diuretics, and the patient deteriorated like hell. So at least when you are going to start the therapy, you should remind the patient that these are the possible consequences that you might have because you are starting diuretic therapy, and always use a beta blocker, and you forewarn the patient so that if anything turns awry, you are safe. So that is the lesson I wanted to put forward because I experienced this thing in my place here. Now, the question about this tachycardiomyopathy. So a definition was given by Brugada sometimes back in 1993. So his definition was heart failure due to tachycardia, due to either systolic or diastolic or both. So what is your comment on that, Dr. Kara?
Regarding this, diastolic dysfunction can be found in many patients with tachycardiomyopathy. And regarding this definition, the basic problem is the more better definition of the tachycardiomyopathy is in relation to that has been given recently, that wherein not only the tachycardia, apart from that, the asynchronous or dysynchrony of the ventricular contraction can also lead. And regarding the systolic dysfunction, it is obviously evident, but I think the more recent description of the tachycardiomyopathy, recent definition, is a more elaborate and more better one, which incorporates all the entities that are there which are causative in the tachycardiomyopathy. Because not always, like for example, in PVCs, not always they need to be persistent to be a cause of tachycardiomyopathy. High PVC burden over a period of 24 hours can also lead, but a particular period of time the patient might not be developing into tachycardia. So I think the more recent definition of tachycardiomyopathy has been given recent times, that is more better rather than the previous term of previous definition.
Okay, thank you. And one question, I think one is will be the last question of this symposium to Dr. Mani, because you are talking about this peripartum cardiomyopathy. So you are talking about the granulomatous heart disease, sorry. So for argument's sake, since you have got Aschoff nodule in the heart in rheumatic heart disease fever, so do you call rheumatic fever as an example of granulomatous myocarditis for argument's sake?
Yes, sir, there has been certain arguments, but what I found is this rheumatic fever is more considered as a differential diagnosis rather than an entity of granulomatous myocardial diseases, because it is this Aschoff nodules. They are no doubt they are pathognomonic of this diagnosis of rheumatic fever. But the other features, the types of immune responses, the granuloma, components of a granuloma, the presence of fibrosis as a healing procedure, and the active inflammation surrounding these granulomas, they are not that obviously present in patients of rheumatic fever. So if you study granulomatous myocardial diseases, there is not much discussion about this rheumatic fever. Rather, it is kept in a group of differential diagnosis, just particularly for the histologists to differentiate it that it is not a active case of rheumatic fever. And because those patients, suppose those acute rheumatic fever, the age range, the presentation, and the clinical presentation also, they are so much different from this sarcoidosis or a giant cell myocarditis or maybe cardiac tuberculosis. So it is not, I have not found it as a entity within this granulomatous myocardial disease. It's as a separate thing.
Now, one more question about this peripartum cardiomyopathy. So there has been reported in literature that in many cases of peripartum cardiomyopathy, there is a high incidence of myocarditis also. So what we call peripartum cardiomyopathy are some of those cases actually myocarditis which are developed and later on they have resolved?
So actually the role of myocarditis is controversial. Still now there is no definite papers or any documents that can say that myocarditis has the role or myocarditis is the predominant thing in peripartum cardiomyopathy. Because there is some inflammation, there are some other etiologies, but sir, myocarditis has no definite impact on peripartum cardiomyopathy.
No, it comes as a potential diagnosis, whether it's myocarditis supervening on pregnancy or it's a plain and simple case of peripartum cardiomyopathy. So that's something you are not able to pinpoint at times. Anyway, I think we had a very nice discussion. Thank you all the speakers. Thanks to my chairperson and thanks for the organizer, our favorite Dr. Shantanu Guha, who has arranged this program. Thank you everybody. So we can close the symposium right now.
Thank you.
Thank you very much. Thank you, Shourosh. Thank you, Shumanta, and all the speakers. Can we